So, what happens when our ultimate evolutionary protection suddenly becomes a deadly trap? Think about it. When the brain, due to severe injury or illness, starts to swell, it literally runs out of room inside the closed box of the skull. This is what we call an intracranial pressure, or ICP crisis. And let me tell you, the life or death stakes here could not be higher.
Okay, let's dive into this. Welcome to today's Explainer. Today, we're going to decode the incredibly intense, high-stakes medical guidelines that critical care teams use to stop the brain from literally crushing itself. We're drawing straight from the latest comprehensive review on managing these intracranial pressure crises, and I'm going to walk you through exactly how doctors fight this invisible but entirely terrifying battle. Here's our roadmap for the journey today. We'll start with the threat, move into baseline critical care, then compare monitored versus unmonitored treatment. After that, we'll trace the steps of escalating the tiers and wrap up with the neuromonitoring arsenal.
All right, kicking things off with Section 1, the threat, or what happens when the brain exhausts its space. You see, an ICP crisis doesn't just pop up out of nowhere. It's usually the devastating aftermath of something major, like severe trauma, fast-growing tumors, or massive hemorrhages. These events introduce extra fluid or mass into a space that, quite frankly, has zero extra room to give. If this mounting pressure isn't controlled, two terrifying things happen. First, cerebral ischemia. The pressure inside the skull becomes so massive that fresh, oxygenated blood literally cannot push its way in, which starves the brain of oxygen. Second is brain herniation. Because the skull obviously won't expand, the swelling brain takes the only exit it can find. It gets physically forced downward, crushing itself right into the spinal column. That is the ultimate danger these doctors are racing to prevent.
And this brilliantly illustrates the concept of intracranial compliance. Early on, the brain can actually adapt a little bit. It might squeeze out a little blood or displace some cerebral spinal fluid just to make room for the swelling. But once that compliance is gone, once the brain has absolutely nowhere left to hide, even a microscopic increase in fluid causes a catastrophic vertical spike in pressure. The system goes from holding steady to total failure in an instant.
Which brings us to Section 2, baseline critical care, known as Tier 0 stabilization. Okay, so when a patient arrives in this critical state, the medical team launches into a rapid-fire series of defense strategies. This happens way before they even look at advanced meds or surgeries. These baseline measures might sound surprisingly simple, but they're absolutely vital. For instance, doctors will immediately elevate the head of the bed to 30 to 45 degrees. Why? Well, gravity. They're literally using gravity to help venous blood drain right out of the head. They also aggressively control body temperature to keep it below 37.5 degrees Celsius because a fever increases the brain's metabolic demand and swells tissues even further. Add to that careful management of blood glucose and making sure hemoglobin is above 7 grams per deciliter, and you guarantee that whatever blood does make it to the brain is actually carrying enough oxygen. Moving right along to Section 3, the fork in the road. We're looking at two very distinct clinical realities here. Now, what's really interesting about this slide is how it maps out the complex branching logic a medical team follows next. It all depends on the technology the hospital actually has on hand. It splits right down the middle based on one question. Is there an invasive intracranial pressure monitor available? On the left, we've got the CIBIC algorithm for when a monitor is present. And on the right, the crevice protocol, which is built specifically for resource-limited settings where doctors have to fight this battle without an internal sensor. Let's contrast these two setups. In a resource-rich setting using the SIB protocol, doctors actually have a wire directly inside the skull. They're waiting for a precise internal pressure data point, usually when the pressure hits 22 millimeters of mercury, before they escalate treatments. But under the crevice protocol, doctors are essentially flying blind without those instruments. They have to rely entirely on outward physical observation and repeated brain imaging just to guess what the pressure is doing inside that closed box.
In that unmonitored CRVC's pathway, doctors are anxiously watching the patient, like a hawk, for something called clinical neuroworsening. This is the terrifying physical proof that the brain is failing. They're looking for pupils that suddenly become unequal in size, a rapid drop in motor reflexes, or the infamous Cushing's triad. That's a bizarre, scary combination of skyrocketing blood pressure, a plummeting heart rate, and slow, irregular breathing. When they see those signs, they know for sure they are losing the fight against the pressure.
That leads us right into Section 4, escalating the treatment tiers. This is where the medical team really starts raising the stakes.
Let's move to and see how this builds. If the pressure crosses that 22 millimeters threshold, or if the patient shows those clinical signs we just talked about,
Baseline care just isn't enough anymore. The medical team has to step up. The protocols escalate through 3 clear tiers. It starts with Tier 1, chemical treatments with hyperosmolar therapy. If that fails, we jump to Tier 2, manipulating breathing and blood pressure. And if that fails, we hit Tier 3, which involves the most extreme surgical and metabolic last resorts.
So detailing Tier 1, doctors deploy hyperosmolar therapies. I want you to think of these like massive, heavy chemical sponges. They push drugs like mannitol or hypertonic saline into the bloodstream. These dense, highly concentrated solutions travel up to the brain and physically suck the excess water right out of the swollen brain tissue, pulling it back into the blood vessels to be flushed away. It is literally a race to dehydrate the brain just enough to relieve the pressure without causing total systemic failure.
Now, if the chemical sponges are quite cutting it, we enter the fascinating physiology of Tier 2. Doctors will actually use the ventilator to force the patient to hyperventilate. Breathing really fast blows off carbon dioxide, and a lower CO2 level tells the blood vessels in the brain to constrict, literally shrinking the volume of blood inside the skull. Pretty wild, right? They might also do a MAP challenge, intentionally spiking the patient's blood pressure with drugs to test if forcing blood harder into the brain actually improves its internal blood flow.
So the crucial point here is that Tier 3 is the absolute final defense. This is the ultimate last resort. This is when doctors pull out all the stops. They might induce a deep barbiturate coma, dosing the patient until their brainwaves nearly flatline, effectively shutting off the brain's electricity so it stops consuming oxygen. They might induce mild hypothermia. Or, as a surgical last resort, they'll perform a decompressive craniotomy, which means literally sawing off a large piece of the patient's skull to finally give that swelling brain some physical room to expand.
All right, let's take a breath and head into Section 5, the neural monitoring arsenal. This is all about high-tech prediction. While those interventions we just covered sound incredibly intense, modern neurocritical care also has this whole other side of scientific wonder. Even when doctors can't drill a hole in the skull, they have these mind-blowing non-invasive tools. They can use a transcranial Doppler, literally bouncing ultrasound waves off the arteries and the temples to accurately guess brain pressure based on blood flow. They can use an ultrasound on the eyeball to measure the optic nerve sheath diameter, because get this, since the optic nerve is an extension of the brain, high pressure inside the skull physically inflates the sheath behind your eye. Or they can use an infrared camera, a quantitative pupillometer, to precisely measure how the pupil reacts to light down to the millimeter. It's truly amazing tech.
For patients who do have internal monitors, advanced computers are running continuous calculations like the Pressure Reactivity Index, or PRX. This algorithm analyzes the rolling relationship between the patient's body blood pressure and their brain pressure. It actually finds the exact sweet spot, the personalized, safe cerebral blood flow zone for that specific person. It goes to show that there is no one-size-fits-all target here. Every single brain injury is entirely unique.
But you know, pressure is really only half the battle. Doctors are also laser-focused on this critical number, 20 millimeters of mercury. This is the critical threshold for brain tissue oxygen tension. Using a tiny probe inserted right into the brain tissue, doctors measure the actual oxygen available to the cells. If that number drops below 20, despite all the blood flowing in, it means the brain tissue is actively suffocating on a microscopic level.
And that brings us to the absolute cutting edge, the most extreme monitoring step out there, cerebral microdialysis. Here, doctors place a semi-permeable probe into the brain tissue to pull chemical samples and continuously analyze the brain's internal chemistry in real time. They're watching levels of lactate, pyruvate, and glucose. They're basically sampling the chemical exhaust directly from starving brain cells to catch mitochondrial dysfunction before the damage becomes irreversible.
From elevating the head of a bed, to chemically manipulating the blood, to tracking real-time cellular chemistry, managing an intracranial pressure crisis really is one of the most intense arenas in all of medicine. But it leaves us with a fascinating, provocative thought. As our neuromonitoring arsenal grows more advanced, allowing us to non-invasively predict and map the brain's real-time functions, will brutal extreme measures like sawing off a patient's skull soon become a relic of the past? It's an incredible thing to think about. Thanks so much for joining me on this explainer, and as always, keep your curiosity alive.